what I'd like to do then is continue along talking a little bit more about this whole idea of medically unexplained symptoms or functional somatic symptoms, the idea of these common symptoms of fatigue, of pain, of all these other kinds of things that are so prevalent in the community and in primary care, and to think more about what might be going on. If we can't find a clear illness, a clear medical or disease, a clear medical disease explaining these things, what might account for these symptoms? And here's some of the things that we find in association with common symptoms. The first thing is negative affectivity or neuroticism. This is a personality trait. Those of you who know sort of contemporary personality theory know that the psychometric theory argues that there are 5 big factors that you can find from around the world from using many different kinds of personality tests, and one of these is a dimension called negative affectivity. And this is associated with high levels of symptom reporting. To some degree, it's circular because the questions that define negative affectivity are, do you have a lot of complaints and physical symptoms and so on? But even if you take those away and you use other ones, you can still find this kind of dimension, if you will, of this kind of distress in people. Another thing that's associated with reporting many medically unexplained symptoms is a lot of childhood illness experience. So there's something that goes on in which children spend a lot of time in healthcare settings, either because they have illness or because their parents are worried about them having illness and so on, that may reinforce illness behavior. And so, and we'll talk again about what some of the processes might be underneath that in a moment. Another thing that is found is a tendency to make pathologizing attributions, or more particularly, more accurately perhaps, a less likelihood of making normalizing attributions. So let me explain what I mean by this. Whenever you have a symptom, you have something that happens, you're sitting here today and you start noticing that you're feeling a little bit warm. And you can think, ooh, am I getting a fever? Or you can think, it's warm in the room. Or you could think, oh, I must be feeling embarrassed. I mean, those are all possible explanations for feeling warm and flushed in the face. The first one is a somatizing or an illness attribution. I have a fever. The second, that it's warm in the room, is what we could call it's an external attribution. It's also a kind of normalizing attribution because that's not a pathological condition. It's just an ordinary state of affairs. And the third is a kind of psychologizing attribution. Oh, I wonder if I'm blushing or maybe I'm feeling embarrassed. Those are all available to us all the time, and in reality, we're all doing that kind of processing all the time, right? I mean, and as you get older, I can tell you, sorry to tell some of you, you do more and more of that kind of explaining of things. And you have a range of things to attribute symptoms to, based on your own experience, based on what's available to you. And the most common types of explanations, the healthy ones under other circumstances, are to normalize things. You know, you feel a bit stiff and you think, I need to get more exercise. I must have not slept well last night, or I'm out of shape or something. And that's it. Or you feel a bit of your heart pounding and think, oh, maybe I had too much coffee today or something. You know, you come up with some explanation that reassures you, and that's the end of it. And that's a normal process of managing everyday experiences by attribution. Well, it turns out that if you look at people who have a lot of medically unexplained symptoms and people who go for help a lot for that if you just give them a paper and pencil test where you say, okay, suppose you had a headache, what are all the explanations you could think about? They don't generate as many normalizing explanations as other people. So they're less able, for whatever reasons, or less likely to explain away symptoms and reassure themselves. So this is an area we've been particularly interested in because this attributional process, which is a very cognitive process, is one kind of thing where you can see culture operating all the time. And it's also a very malleable thing. It's something that you can work with in cognitive behavior therapy and so on with people to modify. So there's a lot of interest in the role that these kinds of attributions might play in symptom experience. Anxiety and depression are both correlated with these symptoms. I mentioned already, I showed you some of that evidence, so these can be part of it. When you look at clinical samples of people in a clinical setting, you find a much stronger correlation in anxiety and depression and these symptoms than you do when you look in the general population. And that's because of a kind of bias in epidemiology that's called Bergson's bias. Because if you look at a clinical sample, you're seeing people who've come for help. Take the example of fibromyalgia. Fibromyalgia, muscular aches and pains of the type we were talking about earlier, is very common in the general population. Most people who have that for a little while don't come for help. they manage on their own. They take an aspirin, Tylenol, they go for a walk, they just say, oh, I need to get more sleep, whatever. Those people who do come for help have a significant prevalence of depression. It's not because the depression necessarily caused their symptoms, but the combination of the symptoms and the depression is enough to make them think, I can't bear this, I got to go for help. So this is a general problem in epidemiology. It's not specific to fibromyalgia or anything else we might want to talk about. When you look at a clinical sample, you see a subset of people who've been driven to seek help, and things that might push a person to seek help are then mixed into the sample and overrepresented and may appear as a high proportion in that sample, when in fact they're not directly related. They're related to help seeking, in other words, not to the specific symptom you might be looking at, or at least that's a possibility. I've mentioned life stress. Clearly, when you ask people, what's going on with your symptoms, you get stress explanations, and you can show those correlations more generally. And then history of trauma. And this is an area of great interest and has been in recent years because of the idea that somehow severe physical or psychological traumatic events could leave a mark and be expressed in a lot of somatic symptoms, and in particularly unexplained somatic symptoms. So there's been a lot of interest in that. And there are a variety of kinds of studies that have looked at this. This relationship is found a lot in the United States, not a lot in other places, so it raises interesting issues about cultural modes of explaining and talking about things. But years ago, James Pennebaker, a social psychologist who studied physical symptoms a lot, did a study with one of his classes, big psychology class, where he asked people to rate a long list of symptoms. And then he asked them, as an anonymous questionnaire, he asked them, have you ever been abused, or have you ever, had any kind of sexual, I don't remember the exact questions, but there were some questions he asked about sexual abuse and so on. And he asked, have you ever told anybody about this? And what he found that was very interesting was that there was an association between somatic symptoms and a history of sexual abuse that the person had never talked about. So this kind of fit with a theory that said there is some kind of cost, some kind of cognitive, emotional, physiological cost to having had a bad experience and never being able to talk about it, or feeling you can never talk about it. So it doesn't go away, you have to rehearse it and keep putting it away, keep suppressing it, and his argument was that kind of suppression was having an effect and resulting in physical symptoms. So this is an intriguing idea. There's some evidence for this. It's not, I think, as well supported as one might like, so this is another dimension. Yes, there are hereditary factors. Negative affectivity, for example, the personality dimension I talked about, is a heritable trait. So that's one way in which hereditary factors come into play. If you have parents or grandparents or whatever who are very crabby people who had lots of symptoms of distress, you're at increased risk to have that personality trait and to show that yourself. That's one pathway. There are other dimensions. So as I show you some of these other things, you can imagine how some of these other things have hereditary components. But as with most hereditary psychological things we talked about before, these are non-specific in the sense that they can lead to many other things. They don't just lead to medically unexplained symptoms, let's say. It's not a straight pathway. And they are, by themselves, most of these things, modest influences. That is, they're not sufficient by themselves. They're just one other factor that piles up with a bunch to give rise to things. Something like negative affectivity, for example, it depends a lot on your life experiences how much you're going to express that personality trait. You can have that trait in a mild form, and if you have a lot of adversity in your life, you'll probably show it, express it, and show the consequences of it in a much stronger form. So this is a model based on that this kind of research, a lot of research on symptom experience and reporting and other kinds of things that puts together some of the factors that likely play a role in people's experience and expression of physical symptoms, not only of medically unexplained symptoms, but actually any symptom. Most of what I'll have to say now has to do with somebody with with heart disease who actually has identifiable heart disease and how much they're experiencing or reporting their symptoms, or anything else we might think of. So at the top you see two boxes. One says physiological disturbance, so things can happen that disturb your systems. For example, you can drink too much coffee and have your heart beating too quickly, as I was talking about before, or you can drink too much coffee and have stomach pain. Or disturb your gut and have abdominal pain from that. You can also have a lot of emotional arousal, and it will give you similar kinds of symptoms, depending on the type of emotional arousal. Depression causes one set of symptoms, anxiety another set of symptoms, anger another set of symptoms. They overlap, but they're somewhat distinct, so you can get symptoms that way. What happens then is, do you pay attention to these things or not? They're going on, whether you pay attention or not, they're sort of there to some degree. Maybe like a background, you can think of it as a kind of white noise in the background. And the question is, do you pay attention to it? Now, why you pay attention to it has to do with a lot of factors. James Pennebaker, I mentioned earlier, did a lot of interesting studies to show that the attention you pay to things depends on environmental circumstances. If you're a runner, cross-country runner, and you run on the same track, a little like we used to have in my high school, a little track in the back, you know, and you just run around. It's a small track, and you're running around the same track over and over again. You'll experience a lot more fatigue and muscle discomfort than if you're running across country on an interesting environment. You know, and it may even be harder to run cross country on an uneven ground, but you will go longer and experience less distress. Why? Because your attention is drawn to things outside instead of to your body. And so you're just not paying as much attention to the discomfort you have in your body. So that's a very simple example. Another interesting example he did was he went to movies and he rated he recorded the amount of coughing in every like 1 minute period of the movie, and then he took the movie and he had a panel of people rate how interesting is the movie at this point from moment to moment. And you can show a very clear correlation. Boring parts of the movie where people agree, yeah, that's a pretty boring part of the movie right now, the level of coughing goes right up. So what's going on there? Well, I mean, everybody's got a little phlegm in the back of their throat. I'm sorry to remind you all of that right now. But anyway, and then what's happening is one person is clearing their throat, and whether you hear that or not and pay attention to that or not depends on how absorbed you are in the movie. If you're very absorbed, you're not even paying any attention to that, you just watch the movie. If you're not absorbed, you notice that. It makes you pay more attention to your own throat, and you notice, I can't resist it anymore now, that you have to clear your throat. So it's an attentional process. It's also a social process. You notice that there's that interaction going on, both in terms of the external environment and stimulus and your relation to other people. How much attention you pay to other people is not a neutral phenomenon. It depends on how much you like them, how much they're like, you feel like them, that they're similar to them, and so on. All these other things are playing a role. So you've got all those dynamics all around attention. Once you notice something, once you pay attention to it, you have what we just talked about, this attributional process. Okay, I notice I have this thing in the back of my throat. I wake up in the morning and my throat's feeling a little bit sore, and I start thinking, could it be that I'm getting a cold or is it just dry? You know, I mean, I've got different explanations available, and what I'm going to think is going to be based on what's been floating around. A man of my age who wakes up in the morning and feels pain in his chest is likely to start thinking, I wonder if this is, you know, a cardiac problem, you know. And if, moreover, if you have a friend who last week had a heart attack, that's going to be much more salient in your mind at that point, and you'll think that much more. It'll be harder to get it out of your mind to convince yourself it's not important. So this is all process of attributing sensations. You can attribute them to illness. If you attribute them to illness, then the question is, okay, how serious is this? And are you going to say, okay, yeah, maybe I'm getting a cold, no big deal though, I'll have a cup of, you know, tea and honey and get on with my life? Or you worry, oh, I hear there's a horrible flu virus going around, this could be really serious, and you start worrying more. At that point, if you start worrying more and catastrophizing, you create more emotional arousal. So I've drawn some of the feedback loops. They can exist at many levels. I've only drawn a couple of them, but this is a particularly important one because at that point, if you have made certain attributions and now you start catastrophizing and you get very emotionally aroused, you've now got lots more symptoms. Because as a result of having all this worry and adrenaline floating around in your body now, you actually generate new symptoms. So this is a vicious circle, and this essentially is part of the vicious circle that is the theory, cognitive behavioral theory or emotional theory of cognitive emotional theory of panic attacks, essentially, or if it goes on more slowly, of hypochondriasis. It goes through indolent, slow, vicious circle, it's hypochondriasis, very rapidly escalating one, it's kind of a panic attack for people. There are probably other differences too, but there's a lot of similarities in those two situations. Well, once you've decided you have a health problem, you have to decide what to do about it. So, maybe, as I say, maybe you just take some aspirin or drink some tea with honey, or take some other remedy, or maybe you say, I better go for help. And then you go for help based on your idea of what's available to me economically, socially, what's appropriate to do for this problem, what kind of healthcare system am I in, and you avail yourself of that. Once you start interacting with other people around your problem, whether it's somebody in your family or going to see a healer or whatever, you're then involved now in an interpersonal process where your way of reporting things is being responded to by other people. And there's interesting work around this. For example, if you complain of pain within a couple dyad, how the other person reacts to the pain has an influence on your pain experience. And the processes can be unintentional and even paradoxical. So somebody who expresses a lot of solicitousness and concern about your pain may inadvertently be reinforcing your pain experience. Somebody who ignores your pain might help to dampen your pain, although they will evoke other feelings of neglect and anger and frustration. So it's a complicated process there. But there is research showing that in chronic pain situations that sometimes couples get caught in vicious circles in which a lot of attention is being given to somebody who's in pain, and inadvertently that's reinforcing the pain, not just pain behavior, but pain experience in some ways. This can happen on a social level. So there's a famous case study in Australia of repetitive strain injury. Some years ago, there were people who started showing up at their doctors complaining of sore wrists. And they were people who were working in video display terminals in the early days of introducing computers, and they were working long, long hours typing in stuff, and they were getting very, very sore wrists. And the doctors who saw this started diagnosing RSI, repetitive strain injury syndrome. The theory was that, you know, having to do this kind of thing for hour after hour was causing micro damage and injuries to the wrist. Not carpal tunnel syndrome, which was another kind of thing, but a problem. People started getting doctor's notes saying, you know, this person has RSI, they need time off work because, you know, this is really hurting their hands and it's a serious problem. And over a period of several months, the frequency of these cases in Australia began to grow exponentially. So at some point it caused some alarm in the insurance companies and other people and thought that this is a problem now, it's going to be very costly, and they started some investigations, and they discovered, first of all, that there was no easy way to document in most cases anything. It's what I said earlier, that it doesn't mean there isn't an injury there, but at the level of what we can do in medicine, there's nothing to show. If you don't have carpal tunnel syndrome or something, you know, more dramatic, there's not much we can show. And so finally the government decided, along with the insurance companies, that they were going to not compensate people for RSI unless there was documentation of some physical injury. So with the number of cases having grown exponentially over a period of time after they instituted this new change in policy, the number started falling away. So it's an interesting issue what's going on here, right? Is it that this problem was created, it was a factitious problem that was just created because people were being reinforced? Or is it a problem that was there and that was just being ignored by a heartless, draconian healthcare system? The other dimension to this thing that you should be aware of is that the people who were involved with this problem were mostly immigrants to Australia who were working in very low-paying jobs in very difficult work circumstances, very long hours. And so it was also the case that not only was this work distressing to them, but that was the only option or avenue they had to get some kind of a way out of their kind of predicament, was to go to the doctor for these symptoms. So there was interesting discussion afterward. First of all, I'd say that the exponential rise and then the decay of this problem with this change in social intervention speaks very clearly to the idea that there can be a kind of social reinforcement, a kind of social looping effect, if you will, that reinforces and changes and reinforces bodily experience. And then there was interesting papers in the journal Social Problems and other places where some of the people involved with unmasking, as it were, the social nature of this reinforcement pointed out that in giving the social analysis, they were also undermining the, removing the sort of agency, the limited agency available to these immigrants who were in a fragile position in the healthcare system. So it raises a very complex ethical question, because the fact that something is reinforced or that something is extinguished does not mean it's not real. As I say, you can, every pain from any cause can be amplified or can be reduced by these phenomena to a degree. So it doesn't mean people weren't having injury to their wrist, but it's a very striking example of this kind of social change. So this is just the same diagram again, just pointing out that we have some processes that we might call psychological in a sense, that they represent how people are managing things like attention and attribution and interpretation. We have processes that we could view as fundamentally interpersonal. How are other people then reacting to you and responding to what you're presenting? or provoking things from you. And then we have larger social processes, which I've talked about here as discursive processes. That's only one way of talking about them. Discursive meaning that these are discourses or languages or linguistic practices that exist, such as the idea that there is a thing called repetitive strain injury, and it is a diagnosis that can be made by certain kinds of clinicians, and it has certain consequences and so on. Calling it discursive highlights one level. It has other dimensions. It has institutional dimensions, it has technology attached to it, and so on. So it's just a way to highlight that this is a larger social process, not strictly interpersonal in a sort of small-scale local dyadic sense, but it has this larger institutional embedding. And so if you think of what can cause symptoms at each of these levels, there are phenomena at each level that can be studied in their own right, can be the source of amplification of problems independently, and could be the source of interventions, could be the target of interventions, in effect. So I think you see how this is where we're heading here in terms of how this very general discussion that I'm giving you, that we could say belongs to health psychology more than anything else, is leading us toward a point of view that we can really make use of to think cross-culturally. And I think it's important because, as I say, it began with pointing out that there was this early literature saying people in other parts of the world outside of the West somatize. They complain of physical symptoms when there's no clear biological basis. They express psychological problems in somatic terms and so on. And I think what I've argued so far to you is that actually that's a universal phenomenon. That's the nature of suffering for most people. And that the balance of focusing on one type of symptom or another, attributing in one direction or another, and so on, has to do with all of these kinds of processes, which are both psychological and socially embedded. So here's how this plays out then in a particular context. I don't know how readable this is, and it doesn't matter too much for my purposes. This comes from some of Devin Hinton's work. Devin Hinton is a psychiatrist anthropologist working at Harvard in Massachusetts and in a clinic in Lowell, Massachusetts, where he works mainly with people from Southeast Asia, from Cambodia, from Laos, and other countries in the region. That's where he did his doctoral work, so he speaks some of the languages of that region, and he's able to work very effectively then with people coming as refugees with a variety of problems. And he has described a series of culture-specific panic attacks. People who get panic attacks, for example, they stand up, they've been lying down, they stand up quickly, and they get a moment of dizziness, what's called orthostatic hypotension. Anybody who lies down for a long time and gets up suddenly might have a moment of lightheadedness. Some people have more than others. Older people, people with low blood pressure, a variety of things. But it's not very pathological, and it just goes. But some of these people from Cambodia and elsewhere will, in getting up, will feel that dizziness and will immediately think, oh my dear, I'm going to have a stroke. That a wind is rising in my body and I'm going to have a stroke. And they have a panic attack. So he's described orthostatic induced panic attacks, which have not been previously described, and which are prevalent in his population. So you have a model like the earlier diagram I showed you, where you can see what the vicious circle is like. You do something physiological. It causes a physical symptom of dizziness or lightheadedness. There's a clear mechanism for that we can talk about, physiological mechanism. You notice it and you interpret it a certain way. That's cultural now. And the interpretation has catastrophic implications to you. So you then have a lot of adrenaline and feel more lightheaded and have other symptoms, and away you go in this kind of vicious circle. He's got a lot of other things written here because, in fact, there are other things going on for people. Because this is a highly traumatized population. There are all kinds of associations people have to that lightheaded feeling. Not only the ethnophysiological idea, the idea that comes out of their own understanding of how the body works in terms of balance of winds and energies and so on, that could be manifested this way, but also remembering traumatic events and so on. And in fact, the possibility that something like PTSD itself and the sort of the sequelae of trauma could contribute to an increased likelihood of experiencing things like orthostatic hypotension in the first place for a variety of reasons. So there's all these different loops going on, but that one main one is, I think, sufficient to make the point. And The intervention, I mean, the main intervention in the current sort of treatment of panic disorder is to teach people to reattribute what's going on, to tolerate the feelings, to not catastrophize and so on, to show them that that makes a difference and give them a handle on the whole thing. And in this case, you can do that very specifically by dealing with people's beliefs and by giving them strategies for coping with it. This illustrates, incidentally, a lot of larger issues, some of which we'll talk about tomorrow, because one of the challenges in thinking about cultural issues is saying, do we need new diagnoses? I mean, where does culture come into play? So should we, in fact, say, this is not now, this orthostatic-induced panic attacks is a separate diagnosis, this orthostatic panic attacks? And should we have olfactory-induced panic attacks? I think the next slide is a slide from his olfactory-induced panic attacks. Oh, this is neck focus, sorry. So the earlier one, sorry, this was olfactory. This is olfactory-triggered panic attacks. So this is a panic attack triggered by certain smells. And he has a whole theory of that in which the smells are causing people to remember traumatic events and so on, and it's causing this thing. This is the neck-induced ones where people twist their neck and feel a bit of dizziness, and that causes panic attacks. So you have, do each of these warrant a separate diagnosis, or do we want to say, look, the basic mechanism is the same, and we can describe it at a fairly abstract level and say this is what happens when human beings experience a threat, feel frightened, interpret the sensations in such a way that it generates more physical sensations of a similar type, and that's the vicious circle. And then now, having that general model, let's add all the specifics, because anytime we deal with this, whether you're dealing with a middle-aged North American man who's worried that the tightness in his chest means a heart attack, or you're dealing with a Cambodian refugee who's convinced that the lightness in their head means that the wind is rising in their body and they're going to have a stroke, that in any case, to begin to talk to them about how to reattribute this and how to deal with this, you're going to have to deal with the culture specifics of where their belief comes from, why they believe this so strongly, what counter-evidence would be for them, and so on and so forth. So I would argue that that's, for this type of problem, that's a better solution than saying we really need 500 new panic disorder diagnoses. In fact, it's open-ended because there'll always be new ones. If somebody invents a new kind of problem tomorrow or finds a new body position to put themselves in, we'll have a new kind of panic attack. So what I've argued in showing you this model is that a lot of problems people have related to somatic symptoms have to do with vicious circles, actually. And that's what makes them into a clinical problem. What makes them really severe, what makes them more than manageable in an ordinary way is the vicious circle. So this is an attempt to say, what would a psychiatric nosology look like if we weren't describing discrete disorders based on symptoms, but we were describing disorders based on the type of vicious circle, which actually is quite interesting both theoretically in terms of mechanisms and clinically in terms of when you're thinking about where to intervene. Because in reality, many of these loops would be involved in any given case, and you intervene where you can. You intervene where you have leverage. It's not always the initial loop that caused the problem that you intervene in, because sometimes you say, well, I can't do that, but I can do the other thing. I can work on another level. So I think this, this is more of a, what can we say, a prospect for developing things rather than a well-worked-out idea, but I think it's something that is interesting to reflect on, that we might have a typology of what I'm calling here looping effects. Calling them looping effects or feedback loops or vicious circles. Using the term looping effects alludes to another idea that I'll talk about tomorrow coming from the philosopher Ian Hacking and about these larger social processes of looping. But the more familiar one for most of us is just this idea of a vicious circle. And as I say, it's pretty well worked out within the cognitive emotional theory of panic and hypochondriasis. It's also interesting to use the same diagram and think about our interventions, because in effect we have interventions that target some of these different levels, and it's part of how you can think about these interventions. We have interventions, for example, that work specifically on attributions. You're very worried about this feeling you have, but we'll give you a different way to explain it and encourage you to use that different way and see what happens when you approach it that way. Or you're very preoccupied with your body, we'll teach you different attentional strategies so that you can not pay so much attention to your body. And that might be by distraction outside, or might be by using your ability to focus very intensely, but training it on something else. So that's the idea behind things like hypnosis, let's say. And then we've got interpersonal methods and so on. Okay. What this model of the psychological processes and social processes of shaping symptom experience implies is something beyond just understanding these types of disorders. Because because it actually has important implications for how we understand symptom reporting in the first place. Because the implication is, whereas in medicine there's an assumption that if somebody tells you they feel hot in the head or they feel tired, that they're simply reporting something that's happening in the body. That's what a good historian is in medicine. Somebody who accurately tells you what's happening in the body, what happened recently in their life, and you can just take all this information down and formulate things. But the model I've just showed you suggests that whatever people are reporting is not simply a product of what happened in their body. It's also a product of what they were paying attention to, how they interpreted it, how other people reacted to it, and that's been happening over time. You know, from the moment they first notice something to to several weeks later when they finally appear in the doctor's office, there's been this loop going on round and round and round over and over again in which there's been a kind of shaping and reshaping of their experience. So this implication at the top that what should be happening in symptom reporting is that something happens in the body and the person has an experience, this one-to-one relationship, and now they report it. And ideally it's just a straight path through. That in fact that translation process is embedded in all of these interpretive processes. So therefore, that symptom report that you get from somebody already contains influences all the way down this kind of process, deeper and deeper into all these social things. So this reality, I think, is not fully taken on board in terms of how most clinicians think when they're talking to a patient. Equally, when researchers go and do epidemiology, they're sort of assuming people are going to give you a report, and that's an accurate index. You know, semiotically speaking, it's what in semiotics is called an index. It's something that just shows that something is there. I mean, a simple index would be if you have fever, you put a thermometer in your mouth, you take it out, it shows your fever. So the position of the mercury or the digital things on the readout are an index of your body temperature. But your subjective experience of whether you're feeling hot or not is not simply an index of your body temperature. It's a much more complex production. It's related to your body temperature, but maybe not so closely. And interestingly enough, in terms of the problems earlier that I was talking about of somatization, of medically unexplained symptoms, people who report many, many symptoms and seek help a lot tend to be less accurate about what's going on in their body. People who are high utilizers of healthcare and who report many, many symptoms tend to be less accurate about what's going on in their body. Why? Because what's influencing their symptom reporting is a lot of this other stuff going on in between. I mean, it's true for all of us all the time, and we can all be in a state where certain things are overriding, but on average, those people who seem to be making very high use of healthcare out of proportion to their medical problems at that point in time, there's more stuff going on between whatever might be going on in their body and their symptom reports. More of this cycling around with them attending, interpreting, other people interacting, all these other influences shaping their experience. This leads to a reflection on, well, what does it mean when somebody has a symptom? How are we going to interpret symptoms? Somebody comes and they're expressing bodily symptoms, how should we interpret these? And we have many ways available, and you can find different literatures in medicine, in psychology, in anthropology, different kinds of literature talking about symptoms in different ways. So as I say, the most basic medical view is that a symptom should be an index of disease or physiological disturbance, right? That the person says they're hot and they should have, high temperature. Or if a person says they feel nervous, they should have signs of a nervous problem. There's also a way in which symptoms can be an index of psychopathology. And I mean this not only that if you say you have hallucinations, you have hallucinations, but that, for example, your way of describing the symptoms could be showing that you have a certain kind of psychopathology. So there is a theory that if you have a lot of physical symptoms, you may, as I mentioned earlier, there's a psychodynamic theory that argues you have a lot of physical symptoms, it's because you can't express your emotions and resolve your emotions effectively. This was given the name alexithymia at some point in the 60s by Peter Sifnios, arguing that many kinds of psychosomatic problems were associated with an inability to express emotional conflict and psychological conflict and resolve it symbolically, and instead it was being expressed through somatic symptoms. So in that theory, if a person reports lots of physical symptoms, it's an indication that they have a certain kind of psychopathology, in this case alexithymia. So that's another way of interpreting these things. Another form of interpretation comes out of the work on conversion symptoms, where somebody, let's say they're blind, they suddenly go blind, there's nothing physiologically wrong with them, this is a puzzle, what could be going on? Well, one kind of explanation going back to Freud and Breuer and up to the present is this has some symbolic meaning. There's something the person doesn't want to see, and therefore they have gone blind. So it's a kind of psychological explanation, symbolic representation of psychological conflict. More commonly, in terms of conversion symptoms, I mean, a common conversion symptom, relatively common conversion symptom, is pseudo-seizures and those are most common in people who have epilepsy. So people who actually have epilepsy, a certain percentage of those people will also have some seizures where they're not having an abnormality in the EEG at that time. So in effect, by their own experience or by being around other people who have seizures and of course they're going to clinics or whatever, they've taken on board this model and it's now expressing, being used to express or expressing distress. So in that sense, it's a representation of an illness model, not of a conflict per se. I mean, there may be a conflict behind it, a conflict over autonomy. I remember a client I worked with years ago who was having struggles over autonomy, and every time that she had a seizure, her mother, she would be rushed to the emergency room, and her mother would rush to the emergency room, and they'd all spend all this time. But when they examined her at the hospital, looking at the EEG and behavioral stuff, she was not having electrical seizures. She had some EEG abnormalities at other times, but she was not having these EEG seizures. But it served a big function to represent her anxieties over autonomy and to engage her mother in this and so on. Symptoms can also be a metaphor for experience. We have a lot of this in everyday parlance. Every language has a lot of metaphors. You're making me sick to my stomach, you're giving me a pain in the neck, this is just one big headache for me. We have similar things in most languages that draw from common bodily experiences to talk about everyday life, and it works the other way around in a sense. I'm going to say more about that in a moment. This idea that metaphor represents a kind of transaction between language and bodily experience, and that can work in two ways. We've already talked a little bit about the cultural idioms of distress last time at the beginning today, but I'm going to talk about this in more length in a moment. But this is the idea that bodily symptoms can be part of a language, a local language of suffering or explaining distress to people. And so focusing on them, talking about one's dilemmas around them can be a way of gaining sympathy and attention from other people. And then taking that a step further, it can be an act of positioning in a local world. That is, if I say, look, I'm really sorry, my back's hurting, I can't take out the garbage today, and my wife has to do it. So I'm gaining a certain local advantage of a very small type out of that illness. And finally, it can be a kind of form of protest or a social commentary. And now, each of these, and there's a lot of anthropological writing, other writing, sometimes some in family theory and family therapy sometimes, where people will talk about a person's symptoms being a form of protest. Now, what I should say is that each of these are possible. They're not mutually exclusive. The same symptom could function in many different ways. Many of them are very hard to prove, in a sense. How do you prove that a symptom is functioning this way? And it's a dilemma, of course. Someone brought up earlier the whole issue around agency. It's a very delicate issue to ascribe agency to people over somatic symptoms that they're experiencing as causing them suffering. So to say, well, this person's chronic pain and their pain complaints are really functioning to change the family dynamics and to communicate to their partner how bad they feel and so on. That may or may not be true. It may be plausible in certain situations, but when you make that interpretation to someone, you're doing a very powerful intervention, and you may really be undermining and sabotaging the person at that point. So I think the issue around these things is not simply are they true or not, but from a clinical point of view, it's also are they useful? Is interpreting the symptom in this way useful, and useful to who? Because in a clinical setting, often these things are used, and when you have a case formulation, they're all trotted out to show what a sophisticated formulation you could make. And you could argue that the use at that point is really for the clinician. Is to show, yes, look how clever we are, we can come up with a good explanation of what's going on. But the more basic question, and ethically important question is this useful to the patient? And certain things may be very helpful for us because we think, now I got a handle on it, now I know why nothing's working, now I know why this person's sick, et cetera, but it may get us nowhere with the patient. In fact, it may even be harmful to the patient. So I caution you because I've been myself at many times in situations where I feel like what's really going on is we're shoring up the profession, we're strengthening our own authority, our own confidence, our own ability to live with our limitations and the fact that we can't solve everything, and we see people who are suffering and we really don't know what to do for them, and they're really having a hard time. And instead of sort of accepting the limits of our understanding and our efficacy, we construct a very elaborate explanation as to why the person is the author of their own suffering. And I see that mostly as a way of just washing our hands and protecting ourselves, and really often of dubious truth value and ethically dubious in terms of its implication for the patient. So let me say a few more words about cultural idioms of distress. As I mentioned, I think this is a very useful idea coming from medical anthropology. Mark Nichter, who originally introduced this based on his work with Havik Brahmin women in South India, where he saw people using a whole variety of strategies or experiences ranging from physical symptoms to complaints about things to actions like being silent or like burning the dinner or so on as ways of communicating distress. And the idea that this came from a range of options that were available to people, and that rather than just viewing things as somatization or as some kind of having some kind of basis in psychosomatic process, that things could be understood in a communicative framework as part of a communication process. More recently, he wrote an essay talking about what happened, the first reference I have here, about what happened with this idea of cultural idioms of distress, in which he, to some degree, rued the whole idea, because this paper of his has been very widely cited. It's a very popular paper. It's had a lot of influence in medical anthropology, and he said he kind of regrets it, because this was not meant to be an absolutely clear, rigid idea that people could then operationalize and apply in a reliable way. He was trying to provide an antidote to a perspective that he felt was ignoring these communicative interactional processes. And what he wanted was just to open people's minds to thinking about the range of these things, rather than implying that an idiom of distress is such and such, and we can now count them up and describe them everywhere. So this is a caveat kind of that coming from the originator of this idea. And he's a medical anthropologist who worked in a variety of areas, works, and hopefully will be here for our summer school in global mental health. But his early work was actually in psychiatry, working in a psychiatry ward as an anthropologist, ethnographer, and so on. If you look at the list that I showed you last time of the culture-bound syndromes in DSM and similar lists, you can find a bunch of these that, among other things, function as somatic idioms of distress. That may not be the only thing they are. Some of them may be syndromes, some of them may be explanations, but one thing they can be is a somatic idiom of distress. And the most familiar one, for me anyway, is nerves, because I have my grandmother was someone who used to complain of her nerves and having many symptoms related to that, so I had a lot of intimate experience. And I had a very important moment with her one day that led me into this area of somatization. You know, if you talk to anybody, any healthcare practitioner who works with a certain area, they work with alcoholism or they work with schizophrenia, there's usually some biographical reason why they have a special patience, a special concern, a special affinity for working with that problem. Because it's all challenging, and one person's enthusiastic topic is too difficult or boring or whatever to another person. So in my case, I got very involved with hypochondriasis and a lot of other things, and it has both personal meaning but also family meaning. And in this case, my grandmother used to complain a lot about a lot of different symptoms. And there was one moment when I said to her, you know, Babi, the Yiddish term for grandmother, I have the feeling that no matter how much you suffer, no matter how much you try to tell us how you're suffering, no one really understands how much you're suffering. And she got tears in her eyes and she said, "You understand me." So I think when we're trying to understand this kind of, incessant and repetitive complaint, we need to understand this kind of existential predicament where this first person feels, for whatever reasons, developmental, personality, the responses of other people, that they're not being heard. And so they have to keep going on and on. There's another story about this. Izzy Pawlowski, an Australian psychiatrist who is very involved with introducing ideas of illness behavior and abnormal illness behavior as a way of thinking about psychosomatic problems. One of his colleagues, Rob Barrett, described how when he was working with someone who had many somatic complaints, he would sit down very patiently and ask them about each one in great detail. And after they went through all the stuff about their headaches, and then they talked about all the stuff about their fatigue, and he'd say, is there anything else? And he would just give them the sense that he was willing to sit there forever. And it was a profound experience for most of these patients because they had worn out everybody else, right? Nobody else had any time for them. And particularly psychological practitioners who always had the attitude, well, let's get enough of this physical stuff. Tell me what the real problem is. Aren't you emotionally distressed? Or isn't your marriage a problem? Try to get to where the real action is. And by simply taking each of these somatic symptoms very, very seriously and going through each of them, eventually he would have great rapport with this person. And eventually, most often, they themselves spontaneously would mention other things, would mention emotional things, would mention relationship things, and so on. So there's this kind of process of feeling recognized, feeling understood in your primary experience, your bodily experience. And again, I think these are people who are suffering this way have probably have a lot of bodily distress in the first place, have probably had a lot of experiences of people not listening to them for a variety of reasons, and need this kind of empathic listening that does not shy away from the extent of their experience. Of course, this runs directly counter to the idea that somehow you're going to be reinforcing people's symptoms by listening to them. So these are countervailing forces that you have to think about at different moments in somebody's evolution. Arguably, it's after you've borne witness to all these symptoms that it may be possible to tell somebody, you know what, maybe talking less about this now will be helpful, and let's figure out how to do that. So we've got lots of examples here. Nerves is one of them. I'll mention some of these others as we go along. Let me take the example of Hua Byung for a moment. Hua Byung, which is a Korean, been described as a Korean culture-bound syndrome by Kemming Lin and others who did work on this. Hua Byung means literally fire illness. And fire, as you may know, in Chinese medicine, Korean medicine, is one of the 5 elements, the 5 evolutive phases out of which everything is made, including the body, and imbalance of those elements can explain illness in traditional Chinese medicine. But each of these elements is not just a physical substance. It is a physical substance. It's also a kind of energy, and it also has manifestations at many levels, so it has emotions attached to it. And you might not be surprised to know that one of the emotions attached to fire is anger. That's probably a cultural universal. It has something to do, again, with the physiology of anger, that we get hot when we get angry. That's related to what the physiological processes of getting angry and the communicative value of it. But in Korean understandings then of this anger, one of the things that causes this anger is interpersonal injustice and feelings of indignation. So it not only is a word or an illness that alludes to the possibility that there may be anger in the background, but it also alludes to the idea that this may relate to an interpersonal situation of injustice. And in fact, there's writing suggesting that at a larger societal level, there have been cultural notions within Korea of a sense of collective injustice, where Koreans have suffered at the fate of the Japanese and others in the region, and this notion is called Han, the sense of collective injustice and indignation that people feel. So on the one hand, Hua Byung is often felt as a burning in the epigastrium, that you have a burning feeling in the esophagus. But it also has this meaning of anger. It also has this meaning of interpersonal injustice. So if somebody comes complaining of burning in the epigastrium to a doctor here in Montreal, they're going to get gastroscoped to see, do you have peptic ulcer disease? Do you have gastroesophageal reflux? They'll get a prescription of antacids and an H2 blocker, and the assumption will be you have a physical problem. We know what category that fits in. To a Korean psychiatrist, incidentally, this is not, and the Korean psychiatrists I've spoken to do not view this as a culture-bound syndrome. They see this as a folk explanation related to Chinese medicine. And to somebody listening to this in that mode as a cultural idiom, you might well want to ask questions about relationships and about feelings of anger and injustice. Even though the person might not consciously be doing that, they were likely to think that all these things are related in some way. And they may be focusing on the element that's connected. So this is an example of something that has been framed as a culture-bound syndrome, might be more accurately understood as a kind of explanatory model based in culture, and that can also function as a cultural idiom. These are some examples of idioms that may be associated with depression. Teresa O'Neill did some work in the Flathead Reservation in the United States, looking at Vietnam veterans, American Indian Vietnam veterans coming back to the reservation who were going through many of the symptoms that we would view as being part of depression. But the typical way they talked about it was as loneliness. So this is a different language of distress. It would not, if you came and talked about loneliness to the average psychiatrist, they would probably not think about depression particularly. It would not be the first thing that would come to mind. One of the other things on here for China is, and here my accent or my inability to pronounce and speak these languages starts betraying itself, but anyway, Shenjing Shui Ro, which translates essentially as neurasthenia, nervous weakness. This was a common diagnosis until recently in China and many parts of Asia. Interestingly, it originated in the United States in the 1800s with the work of George Beard, a neurologist, who proposed the idea that certain kinds of problems of fatigue and enervation could be due to a depletion of nervous energy. So in the neurology of that time, this was a plausible kind of explanation. And this idea traveled globally. It became a popular idea everywhere. And long after it had been given up on to a large extent in North America and other places, it persisted in China and Japan. And it was the most popular explanation for things that we would otherwise label as depression. And in fact, in the 1980s, Arthur Kleinman did a study in Hunan where he diagnosed a group of people who'd been or assessed a group of people who've been diagnosed with Shenjing Shui Ro, and he applied DSM criteria and said that virtually all of them could be diagnosed with major depression. They fit major depression very well. And in fact, when you gave them antidepressants, as he was able to do in the study, many of them got significantly better in some of their symptoms. But most of them did not feel that they were cured. They still had Shenjing Shui Ro. And the reason is that they had other symptoms and other understandings of the nature of their suffering that were not encompassed in the template of depression. And in particular, the nervous weakness that they saw, many of them related to terrible trials and privations that they had had during the Cultural Revolution, in which they had suffered greatly, you know, the terrible cataclysm in the whole society, with really many profoundly tragic stories. And talking about the impact of those events, not in terms of the injustice of those things, which was very difficult, very politically loaded, dangerous thing to talk about, but talking about your own state of depletion, of being broken down, of what had damaged your nerves, was a relatively safer way to talk about this kind of suffering. And that problem was not resolved by giving people antidepressants. So it points out also how you can have this illness category, disease category, let's say, of depression. You can recognize it even in a very different cultural context, but it's being expressed through other idioms, and the idioms have a life of their own. They're not totally subsumed by. So even though you could say, okay, these things map onto depression to some degree, they map onto other things also. There's not a one-to-one mapping at all, and they have their own implications, because they're also languages of suffering, and of suffering that may be larger than any particular disorder that you might be able to identify in a person. Let me see if there's another example we should pick here. Well, I'm going to talk about Feng Tap and Wat Wook in just a moment. And most of these things that you see here are, I think you have this paper and you're reading this chapter, and you have readings and you have some other things, so you've got descriptions of all these things if you're curious and you want to pursue some of them. So here's another interesting take on these issues and the relationship between a disorder and an idiom and how these things might play out. So this is data from looking at symptoms of depression in Africa and Nigeria. It's a large survey with many people, and these are it's using a checklist of depressive symptoms, but supplemented with other symptoms that may be common in this African setting. And this is just, first of all, a sort of series of factors that are taken out by factor analysis. So what that means is that you're looking at the way groups of symptoms cluster together, hang together. People who report one of these symptoms tend to report other ones if they have a high loading on the same factor. So here you see loss of weight, feeling down, depressed, or hopeless, feeling bad about self as if a failure, sleep unsatisfactory, excessive bad dreams, poor appetite or overeating. So most of these things are viewed as core symptoms, not the last few, but as core symptoms. Well, I shouldn't say that. Loss of interest or pleasure is absolutely a core symptom of depression. These are, okay, this is a better way to show it here. These are several factors here. We've got 5 factors. And the first factor is got this, what has it got here? It has weight loss, hands and body, or let's just take the high loadings here, because they're not all high loadings anyway. So weight loss, in fact, that's the only thing that's really high on the first factor here. The next one has emptiness in head, fainting spells, fluid inside head, crawling sensation in head. These are not common symptoms you would find in North America. In fact, in North America, if you walk into an emergency room and tell the doctor, I have a crawling sensation inside my head, you're in trouble. I mean, unless they think, okay, maybe if you're taking cocaine and you're having like formication sensations where you get a kind of creepy, crawly feeling in your skin or whatever. Otherwise, the attitude is going to be, this is a kind of bizarre symptom here. Maybe we should be thinking about psychotic illness. In Africa, feelings of worms crawling in the head is a very common feeling a peppery feeling in the head. Very common, non-specific symptoms that people report in equatorial regions. So we've got a whole bunch of somatic symptoms here on factor 2. Factor 3, you've got a bunch of pain symptoms. And factor 4, you have heart beating fast, peppery feelings, nausea, and so on. And there's, if you put together, I guess they did various kinds of analyses. Here is a loading where you're comparing the cognitive symptom loadings, and they all load on factor 4 here. And what you've got is difficulty in remembering, slowed mental operation, difficulty in comprehension, inability to read for long, trouble concentrating on activities such as reading or watching television. Now, if you look in the DSM around depression, you'll see that trouble concentrating is an important symptom of depression. In Nigeria in the 1940s, Ray Prince, who my predecessor as head of Division of Social and Cultural Psychiatry at McGill, was a government psychiatrist working in Nigeria and working with students, and he described a culture-bound syndrome of brain fag. Brain fag in Nigerian British English, fag means tired, and so brain fag was basically tired brain. And this was described among young students who were coming from rural villages to the university, to the big city. They're often the first in their families and their communities to become literate. They were coming from small villages, and were experiencing a lot of stress and strain associated with studying. And then they would complain that I've been studying very, very hard, and my head's overheating, and I can't concentrate, and my brain is really fagged out. And it would be very distressing, because then they would feel they couldn't study, and it was really a very frightening experience. So he described this as a Nigerian culture-bound syndrome. And generations of African psychiatrists since then have worked with this concept. They have measures of it, and this comes out of amalgamating some different symptom measures and showing that, lo and behold, you can find this dimension in the expressions of distress of people with depression. However, brain fag is not only associated with depression, it's also associated with anxiety, it's also associated with money worries, and no psychiatric disorder, but just being very worried about your money, or worried whether you're going to fail in your exams, or all kinds of other troubles. So in that sense, it functions both as a syndrome and as an idiom of distress, and has other meaning. And here you can see, I think, is this the one I wanted to show you? I guess this is the symptoms that distinguish between the presence of depression or not in a logistic regression are these core symptoms that are, in a sense, universal, that we would find also in North America. And these other symptoms are much less specific. So they're operating, they may be the main ones people talk about initially, but they don't hang together in quite the same way. So this speaks to the discussion I already had in relation to attacus de nervios about how are we going to understand the relationship between this huge cultural variation in symptoms and what is discernible as a pattern across cultures. Now, it turns out if you take this same, some of these same questions, for example, years ago, David Mumford developed a somatic symptom questionnaire based on the symptoms reported to doctors in Pakistan. Because most of the symptom measures we have come, again, from the West. They come from a very narrow segment of people. So the symptoms that we think are important come out of those studies. So he went to medical charts in Pakistan. He started listing what are all the symptoms being listed. And he came up with a list of about 42, 46 symptoms. It's called the Bradford Symptom Inventory. And it included some symptoms like feelings of butterflies in the stomach, feeling of heat in the head, a bunch of other things that are common, again, in these cultural and geographical regions, because the issue of heat in the head it's an equatorial phenomenon all around the world. People who live in hot climates are more likely to report heat in the head for some fairly simplistic reasons. But anyway, it becomes a symptom, and it fits with local ideas about hot-cold types of illness, because then you think, oh, this heat in the head might mean that I'm overheating, and that's a whole set of illnesses, and a set of treatments are implied, and so on. So what he did was he took this questionnaire at one point and he gave it to British medical students. Now, a bunch of those students actually were from Pakistan, Britain, and everywhere else being what they are these days, but a lot of them were not. And what he found was that the non-Asian British medical students also reported heat in the head when you asked them point blank. So it raises this interesting issue related to what I was saying before. Whether we report things or not, whether the culture makes them significant or not, does not necessarily determine whether they're happening or not. There are things happening all the time for all of us that we don't think about, we don't talk about, we don't have a category for, nobody else thinks they're important. Unless they get very, very severe, they just sort of are below the radar, as it were. And you can ask people point blank, well, what about so-and-so? And people will check it out and say, well, yeah, actually, I have had that feeling. Just didn't think much of it. In North America, Montreal, if you have heat in the head, I mean, basically it means you have a fever, or you have a menopausal hot flush, or you've just been running like a demon up the hill. I mean, I think those are about the three main categories that you can get away with. It doesn't have a lot of other meanings for people. So, even though it may well occur in other times, it certainly does occur with any kind of flushing or whatever, a little bit. So we're probably having feelings of heat in the head a lot all the time as our vasculature does whatever it does, but it's not salient culturally. So I think that's a generally interesting issue about phenomenology and about the cultural shaping of phenomenology. Okay, a couple more things. So I've mentioned already this notion of that in many parts of the world, people's understanding of what bodily symptoms are related to is not so much in relation to mental distress, but in relation to social troubles. And this has to do with the fact that this inner theater of the mind, which is so highly privileged and which we're so fascinated by in the West, is not where the action is for people in many other traditions. Not all, I would say traditions like Buddhist societies and traditions where there are technologies of the mind that are important will give importance to that inner theater. But in general, in many societies, people are focused on things like interpersonal relationships or on a spirit realm or some other place than just what is happening inside their head in terms of what they view as socially important to talk about. And in those contexts, people often have sociosomatic theories, things that connect things being out of order in the social world and ill health. This is a term that Arthur Kleinman introduced to argue for not only for a better understanding of the experience in certain cultural contexts, but in our own theorizing on how we think about that. So I'll give you an example of sociosomatic theory in relation to some work that Danielle Groslo and I did some years ago looking at Vietnamese here in Montreal. I mentioned this big survey at one point that we did on help seeking. Part of that survey was asking people whether they had these medically unexplained symptoms. Some of those people who have medically unexplained symptoms, we went from a survey to doing very intensive interviews with them. And tomorrow, again, I'll talk about the methodology for that. And so we got these very long interviews of several hours with people about their physical symptoms and what they meant. And in the Vietnamese sample, we interviewed about 20, 25 people from Vietnam. And a bunch of those people, 6 or 7 of them, reported something they called phong tap. Phong tap translates essentially as rheumatism. It's pain in the joints. Again, human beings everywhere, very common problem, more common as you get older, almost inevitable as you get older, and so it's not surprisingly there's a term for this. The Vietnamese understanding of this is this happens for a variety of reasons, aging is part of it, but also exposure to cold winds can cause this. And by winds, I don't literally mean winds, although that's related, but a kind of energy, a kind of force in the world, right? Just like this idea, I talked earlier about the idea of fire in Chinese medicine. So these medical systems have notions of these energies or elements that make up the world that can manifest in many different ways, and these can give rise to illness. So cold winds can give rise to feng tap. And there are particular times when people are vulnerable to feng tap. So for example, women, immediately after giving birth, the body is considered very open, all the pores are very open, and you're at risk for a cold wind at that point. So ordinarily in Vietnam, when you have a baby, a midwife will be there and she will prepare special materials and some herbs and some steam coming from those herbs, and that will help to close your pores and prevent you from getting a cold wind. If you don't have that, then you might get a cold wind, and years later you might develop feng tap as a result of that. So that's an interesting explanation. In other work that Danielle did, it turned out that this kind of process was very significant for people migrating, because when you migrate, maybe the midwives don't come with you, and maybe you're now in a whole new healthcare system where you're supposed to give birth in a different way and deal with everything else, and you don't even have this knowledge anyway. You know vaguely that these things are supposed to be done, but this is a kind of expertise that the midwife would have, not that you would have as a young woman. So you know something's amiss, but you don't know precisely what, and you could not even give maybe a clear account to a doctor, but if you talk to enough people, you begin to understand what the configuration is supposed to be. When we talk even more to these people with feng tap, meaning in the course of this long interview, as trust was built up, as they told their story, retold their story, they started adding other elements. So another thing that they brought up, some of these people, was that, well, another thing that causes feng tap is this coldness of the Canadian climate, that this is a cold place if you're coming from Southeast Asia, and that was aggravated by the emotional coldness that they had been through, because what had happened in many cases, they migrated as a nuclear family, and then their kids went off to Toronto to start their lives, and so they were living for the first time in households where it was just an older person living alone or living with just a few people, as opposed to the extended family that they'd had. So there's another layer now of social isolation, and this is where feng tap starts becoming an idiom of distress. The same as my grandmother would have talked about her aching joints, and she is literally talking about her aching joints, but she's also talking about loneliness, about unhappiness, about other things, for many reasons, partly because, of course, if you were in a lively, happy situation, maybe you wouldn't notice your aching joints so much. But also, talking about your aching joints is a way to let other people know, without putting too fine a point on it, that you're unhappy, that you're lonely, that you're miserable. Another layer that came out for some of these people was they were, in many cases, refugees, had come as refugees to Canada as part of this sort of boat people who had a very, very difficult migration from Vietnam, spent time on boats literally in the South China Seas and facing pirates and so on. And they started talking about horrible traumatic events that had happened, that they'd been on a boat, that pirates had attacked, that they'd thrown people overboard, that they'd seen people killed in front of them. And this was related to their feng tap. So with a long enough conversation, we started getting some traumatic stories too. Now, does that mean the traumatic story is the real story? I don't think so. I think it's another layer. I mean, any one of these stories is good enough to explain some of the meaning of feng tap for them. But it just means that it was another layer of narrating, of trusting, of deciding to explore something because of that situation. That was one idiom of distress. Another thing that people brought up, though, that speaks more directly to this idea of sociosomatic theory was some people mentioned that their unexplained symptoms were due to wat wook. And these could be a variety of symptoms. These are not limited to musculoskeletal symptoms. And wat wook translates, if you go to sort of Vietnamese English dictionary, what you get basically is indignation. And this is illness due to a sense of injustice, that something has happened to you that has really humiliated you or created a sense of anger at injustice, but you cannot talk about it. Because you're coming from a hierarchical society, a Confucian society in which you have to respect the hierarchy. You would be a bad person if you don't respect the hierarchy. It's you who will be deficient if you show that you don't respect the hierarchy. So you have to swallow whatever happened to you. And as it was explained to Danielle, who's doing some of these interviews, one of the people interviewing it told her, you wouldn't understand this because it's a more sophisticated idea than you have here in Canada. But if a person has this kind of humiliation, then it can sort of fester inside them and give rise to all kinds of illness, to heart attacks, to all kinds of physical illness. So this is explicitly sociosomatic theory, because the notion is this injustice has happened and it's going to have bad effects and you will have this physical illness. In fact, the story one person told was related to a kind of humiliation, a kind of love affair, failed love affair with someone who was her superior, and she could not talk about it, and it went on. Now, what wook is not, it's a sociosomatic theory, it's a causal theory. It's not an idiom of distress because you can't actually talk about what wook to other people, about yourself, because it would point to exactly the thing you're not supposed to be talking about. It's the shameful story or the destabilizing story that you have about the hierarchy that you're not supposed to be, you're supposed to be helping to maintain, not challenging. And so what happened in these situations, because the interviewer was an outsider, people would tell the story eventually and then sometimes spontaneously say, you know, this is the first time I've ever told anybody this story. And I can only tell it to you because you're not part of my community. And interestingly, in anticipating our discussions later in this course around psychotherapy, some of these people said, I feel really, really relieved having told you this. So interesting issue about what may be forbidden to speak about and what may actually be beneficial to speak about in the right, safe context to the right person. Because it doesn't mean, having spoken about it, doesn't mean you can now go back and say, great, now I can talk to everybody about this. It still is a loaded situation that would be destabilizing and cause trouble for other people and trouble for you and so on. So you still have to manage it somehow. Okay. So the last thing I want to talk about, I think it's the last, I hope it's the last thing. We're still on track here. So. The last thing I want to talk about is a broader notion that has been central in medical anthropology for some time, of thinking about the embodiment of experience. Embodiment is a term that has been borrowed and used, directly applied from phenomenology, and the notion that there are experiences that are fundamentally in and of the body, and that we need to understand them that way. And partly this became extremely popular in the 70s and 80s and into the 90s. Partly because of actually a bit later than that, I'd say 80s and 90s, because of a neglect of the body in the social sciences and in anthropology. There was so much emphasis on what can be reported verbally, on language, and on the cognitive. And people started feeling like, you know what, this is getting very skewed. If you actually look at how people experience illness and suffering, it is very bodily. And we need a language for that. And that's not only an effect or a consequence, it is in many ways the origin. It's the sort of ground out of which these things are emerging. So the question is how to understand this, how to approach this. And there is a rich literature from phenomenology, Merleau-Ponty and others, particularly Maurice Merleau-Ponty, trying to talk about bodily processes from an introspective point of view, using a phenomenological method to try to describe these things. And that got pushed aside in psychiatry. As I mentioned last time, that phenomenology with DSM-3 became not experience, but symptom checklists. So we're not interested in the texture of your experience now and how one hallucination might differ from another, or whether you might feel this thing in your body or not, but really just, do you have this, are you hearing voices or not? That's it. That's all I need to know, and now that's all the information I need. As opposed to what happens in phenomenological philosophy, which is a much more fine-grained description of experience, with an effort then to describe in more abstract ways what are the dimensions and the parameters of experience. So this has been an important move within medical anthropology, and I've cited here a couple of the key early papers, and then my own intervention in this, which I'm going to explain in a few moments. So what I want to do now is tell you a little bit about this idea of cultural phenomenology. How is it that, because in phenomenological philosophy, there's kind of an assumption that, again, that all human beings are essentially similar. Therefore, any one of us can look inside and find out everything we need to know about human beings, if we're sufficiently observant and clever. And so if I'm a German white male of a certain age and time period, I can write about universal phenomenology, or at least get close to that. Versus the idea that, well, maybe all experience, no matter how intimate and no matter how fundamental, is always culturally framed and culturally inflected, which I would argue for, and which I think demands then explicitly cultural phenomenology. And then I'll say a few words about neurophenomenology, the idea that there might be traces of the body and of the nervous system in our phenomenological experience, and then the question of how to put these together. So here's an example of cultural phenomenology from Japan. These are words about emotion that embody emotion. So one of the key words in thinking about feeling in Japan is kokoro. Kokoro is like the center of feelings. Kokoro is like a heart-mind. Kokoro is here, and this is where feelings occur. So again, you can see some universal elements. Many societies understand the heart as a center of feeling, and the reason for that, again, is because the heart's very reactive to feelings. If you're anxious, if you're angry, if you're sad, you definitely feel sensations here in the body. There are many, years ago, Byron Good and Mary Jo Good worked in Iran and described Narhatya Galb, feeling of heaviness in the heart. And this is a very common idiom throughout that region of the world. And people feel this as a physical sensation in the body, and it's associated with grief and sadness and so on. So there's an understanding this is where you feel these kinds of things. So you have this idea in Japan. You also have the notion that you have another center of feeling, which is the hara, which is over here, just the solar plexus. And most of the Japanese, and then thinking is atama, and that has become more important with Western influence. And there are a lot then of cultural idioms to talk about emotion that reference kokoro and or hara. If you want to say somebody is upright and courageous, and you say haragatatsu, their hara is standing up. So, you know, you can see the analogies. I think I have a bunch of idioms here. Okay. Harakiri, which is not the correct term. That's the crude term for it. Seppuku is the formal term for this ritual disemboweling. And yes, it's cutting the hara. That's where you cut. And the reason you're cutting a center, a feeling, a vital essence. What circulates in the body, in the hara and so on, is this energy ki, or chi, in Japanese ki. And ki is, again, the breath is ki. It's a kind of movement of the spirit from moment to moment. And there are a lot of idioms around ki. So you can have your ki is blocked, your ki is heavy, your ki is leaking. So these are all part of cultural phenomenology. We can see analogies. You can get inklings. It's not totally foreign. When you hear this stuff even for the first time, each of us can probably in our own language, our own background, say, yeah, I have an inkling of what they're talking about. But the specifics are quite different, quite unique. And if you try to take a very specific English idiom and translate it, people will not understand right away. They will see it differently. I'll give you another example. In Japan, a lot of metaphors of the body and of illness are plant metaphors. Human beings are vegetation, are vegetable, or like bamboo, or like other vegetation. In English, if you analogize somebody to a vegetable, it's not at all a compliment. It just doesn't work very well. But in Japan, in Japanese, it works quite well. So there's a whole domain that's coming into play with a lot of images that are conveying this meaning. So this is part of what I mean by a cultural phenomenology in which there's an intimate interplay between particular languages, particular imagery that has a long history, a long cultural history, and that people are using to explain and to articulate suffering, and that then get sedimented and embedded in everyday language, because these expressions I showed you earlier, in a sense, these are literal expressions. They're not viewed as, you're not being poetic now. This is just how you say this. This is just how you say that you have such and such feeling. You see, it's not that you're making a big theoretical statement or that you've come up with a poetic thing. It's just how you say it. So, but there was a history, there was a point at which in somebody's creative language this was a poetic moment, and it followed from a certain kind of experience, and now, you know, hundreds and thousands of years later, it's just part of how you say things. So, and we need to remember this, of course, because the language I'm using right now with you all the time is full of that, right? But it's just, that's just the language we're using when we forget that that's where it all came from. So behind this are ethnophysiological theories of how the body works, of what the body is made up of, the kind of structure of the body, of the energies that flow in the body. So these are images from the central one from Chinese, the other ones from of acupuncture meridians and flows. So that's what I'm going to say for the moment about this idea of cultural phenomenology. I'm going to come back to it in a moment. I want to talk about the other pole now, because that, what I've just said, implies in a way that this is very malleable and we all have different histories. And if you look, for example, in Indian languages and Sanskrit, there's a whole vocabulary of emotion, and the dominant word for all this is rasa, which is taste. And so you have a whole vocabulary around different kinds of tastes for talking about emotions. That has a long history, and it's elaborated in the arts and so on. So you can trace this whole thing, and to do a good job of it, to understand what it is, you have to do a whole elaborate cultural history of how these things, how different people talked about them, how are they used, and how do they now occur in everyday language for people. And the implication is a kind of huge variety, even though we can see common elements, as I say, that if you look for what role does heat play in people's systems, among other things, it will almost always be connected in part to anger, but not only, and not the only meaning. You'll find some of these things, but not that much. So that commonality brings us back to this idea of neurophenomenology. So this image is here to help us think about the idea of neurophenomenology. This is a moire pattern. And the reference you see here is Heinrich Kluwer, Mescal, and the Mechanisms of Hallucination. This is an image similar, I think it's a similar image like this on the cover of that book, I think. If you close your eyes now and press on your eyeballs gently, not too hard please, I don't want to be responsible for anybody bruising their eyes, but you press lightly on your eyes and you wait a few moments, you will begin to see a moire pattern. You'll begin to see checkerboards. So what are you seeing? Where's that structure coming from? This is a very crude stimulus you're putting on your eye. It's just pressure. And what you're seeing is some of the structure of the first few layers of your visual system. So this is a kind of neurophenomenology, right? There's a structure coming out of, here's a crude stimulus, just pressure. And what you're seeing now is a structure. Where's the structure coming from? It's the structure of your nervous system, in a sense. In fact, interestingly enough, if you stop it and then do it a second time, you get a slightly different moire. And I forget which is which. One tends to be circular, one tends to be more vertical checkerboard. So there's a kind of effect, again, and this is related probably, I don't know, probably related to lateral inhibition or something like this. I don't know the details of it, but it's an interesting example of a kind of proto-structure that's there, just given, it's like hitting a tuning fork, and now you're getting a kind of particular kind of, in this case, set of visual frequencies. So that's a crude kind of neurophenomenology. Here's a slightly more elaborate kind of neurophenomenology. This is a famous painting called The Nightmare, and this is an image of this kind of monster sitting on this woman's chest. You see the horse, the mare in the background, and this can be understood as an image of a kind of experience, in this case, of sleep paralysis. I think we might have mentioned this a bit in the first lecture, this notion that there's a phenomenon where you can wake up in the middle of the night and you are paralyzed, and you then, but you're awake, and so then you have this very unusual experience. And I did talk about this a bit last time. So the point is that there again, there's a neurological structure to this experience of being awake yet being paralyzed. It's given to you by the body. It's a very powerful set of experiences. But what happens from the first moment that you have this experience is you begin to try to interpret this, to make sense of this, to the extent that you're conscious. In fact, even if you're not conscious, even if you're dreaming, your brain is also trying to make sense and make patterns and so on. That's what's accounting for the dream story. So you have this kind of circular process, not totally dissimilar to what I was showing earlier around somatic symptoms, in which you're trying to make sense of this bodily experience. So you have a kind of elaboration of this neurophenomenology. So we have, on the one hand, cultural phenomenology, cultural shaping experience. On the other hand, neurophenomenology, the body shaping experience, and then the reality of any actual experience of these two things interacting and producing experience. How to think about this. So this is my last set of slides for today. You guys are, this is where you have to draw on your last reserves of energy here to stay with me. This is where we should have stopped half an hour ago, but anyway, we're going to push on just to make this last point. I think a particularly powerful, useful way of understanding the interplay between the cultural phenomena and the bodily phenomena is through metaphor. And I mean that not by using metaphors, but I mean by understanding the nature of metaphor itself, because we now have a significant amount of work coming from cognitive science trying to understand how do metaphors work, what's going on with metaphors. And we have a convergence, in fact, I say cognitive science because of a convergence between cognitive psychology, philosophy, neuroscience. A lot of different disciplines have been very, very interested for the last 20 or 30 years on metaphor and trying to do basic work on understanding how metaphors work. And one of the consequences of this is to show, one of the early things coming from George Lakoff's work, is to show that metaphors are completely ubiquitous, that language is full, every language is full of metaphors. And in fact, that's how language is built. It's built from a simple vocabulary of bodily experiences into more and more elaborate language based on metaphors. So it's almost impossible to make any kind of a sentence, complex sentence, without using all kinds of metaphors. And those metaphors, as I say, if you start tracing them back developmentally, they come back to very basic bodily experiences. So, for example, well, when I say come back, what am I saying? I'm saying something has gone out and now it's physically coming back. When I say based, what do I mean? Well, I mean something is put on top of something else. And so, as I say, it's impossible to say anything abstract. It's impossible to say anything of any richness without employing all of these metaphors. The metaphors are built on a kind of scaffolding so that more complex metaphors are based on earlier metaphors, and they sort of have a whole history. And what happens over time is they go from being novel metaphors. A poet makes a fresh metaphor and we say, wow, I never thought of that way. You know, and we're excited by it. But when certain things get taken up into the language, you know, the lip of this cup is just the lip of this cup. It's not a lip anymore. But that's how it got to be the lip of this cup. So what's interesting to me is not only are all these things, these dead metaphors, like with the lip of the cup, that's just the literal name for the cup. But what's interesting is as soon as I tell you this, you know, it's very easy to reactivate the metaphor. So what's fascinating to me is that our language is made up entirely of dead metaphors. We ordinarily don't worry about it at all. We process them as literal, and yet it just takes a split second, a Walt Disney movie or anything else, for the metaphor to come alive, and we're amused, and we're engaged, and we're enlivened, and we're thinking in new ways. So there's a clue there, something very important there about phenomenology and about the liveness of language and about the connection between body and language. Because on the one hand, let's see if I segue to my slide, on the one hand, where these metaphors came from, to some extent, is from this phenomenological neurology of embodiment, from these bodily experiences of what it is to have a lip and what a lip is like and what goes through lips and all this other stuff that we've had starting from infancy. So there's a source. Other things feed into it, of course, because we have cultural shaping. So once you have lips of some kind and they're appearing somewhere, it has other meanings, and those meanings are now also going into that metaphor. So it's not just, it may developmentally have come from this simple bodily experience, but it gets other stuff layered onto it very quickly, and that becomes part of it too. And then the metaphor itself is used to think about other things. So this is going on constantly. And because it's possible to bring things back alive again, things can flow in both directions. Developmentally and historically, things came from these bodily experiences. They became our everyday language, and it became more and more abstract and more fixed in a way. And so we don't think of it anymore as metaphors. We just think of that's the abstract technical term for this kind of thing. But we can easily reactivate it. And when we reactivate a bodily experience, because the other thing that we're learning is that cognition is embodied, right? To think, we use our bodies. So, for example, I think I may have mentioned this last time. Well, in fact, I can show you in these next examples. So here's some examples of how these things are connected. We have in every culture notions about posture, about bodily stance. I mentioned already the Japanese metaphor haragatatsu, of your hara standing up, right? Standing up like this, right, in every culture is different than being like this, right? One is a state of dejection and depletion, and one is a state of energy and vitality. And you don't need to know anything about a specific culture. If I told you one is which, one is the other, I think could go around the world with everybody, and they would just like this famous, you know, this famous example from Wolfgang Kohler. This famous example from Wolfgang Kohler, probably all of you have seen this. One of those is called Taketa, and the other one's called Maluma. Can you tell me which is which? Which one is Taketa, and which one is Maluma? Okay, so what are you doing and making? I mean, human beings everywhere in the world can do this. They don't need to know the language this came from. It doesn't come from any language, as it turns out. But anyway, and what you're doing is you're doing a cross-modal analogy or a cross-modal metaphoric mapping. Taketa, okay, auditorily has the same kind of sharp changes that one has, and Maluma auditorily has the other kinds of shapes. So that's a bodily thing. That's a phenomenological thing, right? That's what poets work with, among other things. Why poets will say, contra Ferdinand Saussure, that the relationship between words and meaning is not arbitrary, right? The structural linguists argued that it's arbitrary. Any sign could be attached to any sound. No poet in the world would ever agree with that. They feel, no, it's absolutely it's necessary. It has to be this word because of my bodily experience and where this language came from. Part of that, of course, may be idiosyncratic bodily experience. We all grow up in different environments. We have different tastes, different sights, different sounds, but our language is rooted in those experiences. So I'm using the metaphor of stance. Now I've shown you something about stance. All around the world, language of stance has meaning. It has moral meaning. It has meanings around anger, around confrontation, around social status. To lower yourself before something is to show respect for that, right? Many religions have prostrations as a way of expressing relationship to the divine, to something transcendent. So I'm arguing there's a bodily logic to this, that this is not purely coming from the top down from some very abstract notion, but really coming from the ground up. But it works both ways. Here's a woman wearing a traditional kimono, and she's wearing the sash around her which covers the hara. Right? That's why that's there, to protect the hara. Bodily posture communicates things to us right away. So here's another image of loss from William Blake, his character LOS, loss, in agony. Right? And this bodily posture conveys to us fear, horror, pain. I mean, we get that sense of somebody being torn down right away. So my point is that the language of stance is not arbitrary. It's bodily rooted, but it's used culturally in all kinds of ways, and then things flow in both directions. If you're asked to do a prostration, you feel differently doing that prostration. It's a profound experience to do a prostration. Right? To lie on the ground before someone else or before an image or something is a very powerful experience. And something is changing in you at that moment. You're feeling things differently because you're doing it differently. Even to talk about it, because we're symbolic beings. You don't have to do it. If I start talking about it, if I ask you to imagine it, you're going to start feeling things in relationship to that. And of course, it happens in everyday language. If you say, well, he really prostrated himself before his boss. Well, you have a visceral response to that, right? It's not just that, oh, he adopted the appropriate situation vis-a-vis his boss. No, he really humbled himself, and then it's going to have all kinds of implications for you based on your social code and how you view hierarchy and so on. So this is what I mean by things flowing both ways. I'm going to show you two other examples. Face. One other point about this, about stance. A big, significant portion of our nervous system is devoted to managing the issue of stance because we are two-legged beings who are always at risk of falling. Right? I mean, to stand is a constant active process. When you're standing, you're constantly adjusting your muscles to stay upright. Otherwise, you'd be flat on your face in no time. And what's interesting about that is if you give people a questionnaire to fill out with blanks in it, if they're standing with certain kinds of sentences, you can show, Raymond Gibbs' study can show that people will fill in those blanks with words related to balance if they're standing, much more likely than if they're sitting. So the whole notion of balance, which we see in healthcare systems and so on, and so on, is rooted in this bodily experience. And the importance of, why is balance important? Well, it's important because we literally are doing it all the time. You know, and we would be on our faces if it wasn't. Okay, so that's what I want to say about stance. Face. So face is very important. Faces are very important. Faces are how you recognize the individuality of each person and how you recognize what they're feeling and where they're looking, what they're interested in, by where their eyes are pointing and so on. So a big chunk of our brain is devoted to processing faces. In fact, separate parts of the brain associated with figuring out whose face this is and what is this face looking at, or what is it doing, or what emotion is expressing. These things can become dissociated. I don't know if I mentioned that the other day. You have things like Capgras syndrome where someone will say, well, you look like my sister, but I know you're not my sister. I can feel you're not my sister. So you'll have facial recognition, but not the feeling of familiarity, for example. So you can dissociate these things. Okay, so a big chunk of the brain is devoted to face. Face is very important. Metaphors of face are extraordinarily important around the world, and typically they're metaphors about social relationships and about social standing. Many Asian cultures have literally used the metaphor face and say it's very important to maintain face, to have good face. How are you seen by others? How do you present yourself to others? So again, I'm arguing this is a natural metaphor. It's through our face that we present ourselves to each other, and it can work both ways. So here's a Maori face. This is a warrior culture in which making fearsome faces is an art form at this point. I mean, at one time it was the thing you carried into battle, but it's been refined into a whole art, and you make these terrifying faces that, again, have this dramatic impact of taking a stance with others. And the face, more than anything, of course, is what gives us a feeling of the presence. Face and voice are the ways we feel the presence of another person. So here you see these children in Bali And I think, again, for most human beings, this evokes a very powerful response of caretaking and concern and so on in these children's expressions. And finally, another domain of rich source of metaphors and a way in which cultures are working with metaphors and imposing new structures, our experience of time. Experience of time is embodied, right? Whether we feel that time is going quickly or slowly has to do with how we're present in the moment, how engaged we are, and how we're processing information, but we feel it and experience it very much as a bodily phenomenon. And many cultural situations try to modify time. Most artistic performance is related with playing with time in a way so that you're moved into a kind of mythic time, or you're told a story where, and all the myth cycles, what distinguishes a myth from a sort of popular drama is you know already what the end of the myth is going to be. It's a timeless thing. It's a cycle. You know kind of what's going to happen. It all fits together in a way. So in a sense, at any moment in the myth, you're apprehending the whole pattern. So you're in this kind of mythic time, this timeless time, and that can be modified by our own bodily stance and position. If you sit still and just watch what's happening, you initially will probably experience a feeling of great restlessness and of time dragging, and eventually you can experience a feeling of time of falling back and of timelessness and of having spaciousness. And that's what happens in meditation, among other things, that then teaches you something about our own sense of the urgency of time, of the press of time, and so on, where that comes from. So I'm arguing that all these ideas that we have, some of which seem very abstract, some of which seem to be coming only from the top down, are also bodily grounded, and that the language we use about these in everyday life moves back and forth between these social levels of discursive description and embodied experience, and that each can engender the other. The body can be a source of fresh metaphors, and taking on these metaphors, thinking with them, changes how we feel in our body. You know, if I start talking to you enough about timeless time, you will get spaced out, I guarantee it. Okay. I think we're going to have to stop here. This is just, let me see what I have left here, I'm not sure. This is just an image of a body with the cosmos mapped onto the body. And a fundamental idea in many ethno-medical systems is there's a correspondence between the body and the larger world. And that's behind, again, some of the socio-somatic theories is the idea that if the social world is in order, if the spiritual world is in order, the body will be in order, and vice versa. That there's a kind of correspondence between these two. And so you have systems of diagnosis that use astrological notions or use other things because of the idea that these are somehow in resonance, they're somehow connected and moving in parallel in some ways. And so this leads to different ethno-medical systems. And thankfully, we've reached the end of our talk.